Hello, everyone. So this is my presentation on a giant complication, a case of pituitary apoplexy of a giant adenoma in a patient on anticoagulant therapy. So just a basic introduction, pituitary adenomas represent 10 to 15% of all intracranial tumors. They're classified according to size, more than 1 centimeter representing macroadenomas, and more than 4 centimeters are sometimes called giant adenomas. They're further classified according to the cell type and according to whether they're functioning or non-functioning. So pituitary apoplexy is a rare but extremely life-threatening complication, which basically means a sudden hemorrhage into the pituitary gland. Can happen sometimes in patients with large macroadenomas. Risk factors include the size of the adenoma. With increasing size, increasing the risk of apoplexy, pregnancy, coagulopathy or anticoagulant use, and head trauma. And pregnancy, of course, one of the reasons is the size effect by itself, because in pregnancy, they can be up to 2 times the size, the pituitary itself. So apoplexy usually presents with sudden onset severe headache and visual field effects. These are usually due to the mass effect of the apoplexy, but the more serious problem is the loss of pituitary hormones. All pituitary hormones can be lost, but the most serious one is the loss of ACTH, which can then lead to loss of cortisol, leading to circulatory collapse and sudden death. The learning objectives here are that anticoagulation can significantly increase the risk of apoplexy, especially in patients with large adenomas, and apoplexy can lead to sudden hemodynamic compromise, as we discussed, due to the cortisol deficiency. And the management for that is early initiation of stress dose steroids. So our case was an 80-year-old lady who came in with sudden onset nausea, vomiting, and a headache that started after a fall in which she had hit her head. So she had a history of this non-functioning 4-centimeter pituitary macroadenoma that had been present for several years and was being monitored in the clinic with no significant complications that she was suffering from that. But recently, a few months prior to presenting to us, she had developed a DVT for which she had been started on apixaban for anticoagulation. When she came to us, she was completely alert and oriented. She was complaining of a headache, but otherwise had no focal neurological deficits. Stat head CT was done, which showed extensive subarachnoid hemorrhage and which was involving as well as surrounding the suprasellar mass. Before she even got to the ICU, she experienced rapid deterioration of her neurologic status with a rapidly deteriorating GCS score and had to be emergently intubated. Neurosurgery were already on board. She was taken for a repeat scan, which is shown here, the MRI done here, which is showing basically a large macroadenoma in the middle and the extensive subarachnoid hemorrhage surrounding. She was taken for surgery right away. Ventriculostomy was done with ventricular drain placement for draining all the blood. Over the next few days, I was just basically waiting and watching how she was doing. The ventriculostomy drainage pressure was adjusted by neurosurgery to ensure there was adequate drainage. And the pituitary hormones were being monitored. Levothyroxine was added after she was found to have a decreasing T4 over the next few days. And obviously this indicated that she was progressing towards the panhypopituitarism. Unfortunately, over the next few days, her condition did not significantly improve. And after 10 days, she remained comatose and eventually died. So the point of this discussion is that pituitary apoplexy needs to be recognized as a rapidly fatal condition with an incidence of around 10%, which is not small by any means, in patients with macroadenomas. In our patients, the trauma and the head injury that she suffered, that is probably what triggered the apoplexy in the first place, but the anticoagulation was likely a large part of it as well in the development, as well as more importantly, the severity of the apoplexy. So the conclusion for us was that, through extensive literature review and everything, we could not find any guidelines in place for, the contraindications or any even relative contraindications in such patients for anticoagulation if they require it for any other reason. So we just need to have a frank discussion with the patients about all these risks, potentially fatal complications of anticoagulation in a patient with apoplexy if they are started on anticoagulation, especially, if it's an 80-year-old lady at that age who is not very functional anyway, there's a risk of falls, and especially with the extremely large size of her adenoma, that can significantly increase the risk of apoplexy. So hopefully, over the next few years, we can also come up with some guidelines and some guidance on, how to navigate such situations as well. That's it. Thank you.
We'll open it up to see if anyone has any questions. I will ask a question then.
Go ahead.
My question is, do we know why the patient is because of the potential renal insufficiency or loss of hormones, that comatose states, and lack of thyroid? Expand on that, please.
Yeah, so the comatose state, according to our neurosurgeon, neurology was also on board. It was just that the subarachnoid hemorrhage was just so massive. It had caused so much mass effect as well as fibrosis. Obviously, there's some vasoconstriction. Sometimes that happens with that as well. So basically, it was just that the initial hemorrhage, very severe hemorrhage that had happened. Yes.
Just a little bit, it could be a possibility of this glaucoma, just like what he said. And I was wondering what to do with the therapy was on this patient. If we keep like 35 years of that, and if we check whether or see this was really just apoplexy or basically glaucoma coexisting.
Right. That's a very good question, actually. So in this patient, the hormones were checked on day 1. At that time, all the pituitary hormones were normal, except for prolactin, which was slightly elevated, which you expect in all patients who have this kind of macroadenoma, not from, like, it was not a prolactinoma, but just from the mass effect, because when it's that large, there's a stalk effect, so it prevents dopamine from coming in. So just the loss of that inhibition from dopamine leads the prolactin to be slightly elevated, which was in this patient. All the other hormones were normal. The other point is that, interestingly, in patients with pituitary apoplexy, even if they have panhypopituitarism, you are not supposed to give them levothyroxine in the beginning, because levothyroxine increases the clearance of cortisol. So that can lead to further hemodynamic compromise. So you have to wait for the steroids to take effect before you add the levothyroxine anyway. Yeah.
That's the same thing.
Right.
That's confirmed then.
Right. Right. So this patient developed we were monitoring the pituitary hormones basically every day. So after like 3-4 days, I think that's when the hormone levels started to drop. It was not a significant drop at that time.
Thanks for watching.